Today we are going to discuss the anal pathology, how this anal pathology presents clinically in the outpatient department. Before we discuss the anal pathology, it's very important to know the surgical anatomy of the anal canal. The length of the anal canal is roughly 3.5 to 4 centimeter. The anal canal is divided into two parts. The distal part below the level of the dentate line is lined by the inoderm or skin. It is a pain sensitive, supplied by the somatic nerves, and above the dentate line there is a transitional zone of the anal canal, which is endoderm pain insensitive. The part of the anal canal is thrown into mucosal folds that is known as columns of Margagni. In between the columns of Margagni, there are anal crypts associated with the anal glands, which open at their bases of the anal crypts. Above the transitional zone of the anal canal, there is a lower part of the rectum. Both the parts of the anal canal has a different nerve supply, and the venous drainage and the lymphatic drainage. Lower part of the anal canal, just below the dentate line, is supplied by the somatic nerve, that is inferior rectal nerve, and above the anal canal it is supplied by the splenic nerve or the pain insensitive, that is supplied by the pelvic splenic nerves, which contains both the sympathetic and parasympathetic. It's a pain insensitive, and that below the dental line is pain sensitive because it is supplied by the somatic nerve. The venous drainage of the anal canal above the dentate line is the internal hemorrhageal plexus, and below the dentate line drainage is by the external hemorrhageal plexus. The external hemorrhageal plexus drain into the internal pudendal vein to internal life vein through the systemic circulation. Above the dentate line, the transitional zone of the anal canal drained by the internal hemorrhageal plexus, which drain through the inferior mesenteric vein, because that has got the connection both to the inferior mesenteric vein and also to the systemic veins. The lymphatic drainage of the anal canal is primarily in the inguinal group of lymph nodes, but above the dentate line, because of the connection with the lower part of the rectum, it can be drained into the pelvic group of lymph nodes, that is the inferior mesenteric group of lymph nodes. The blood supply of the anal canal is the inferior rectal artery, which is the branch of the internal pudendal artery. So, truly speaking, below the level of dentate line is the inoderm, which is divided of sweat and the sebaceous glands. Above the dentate line is pain insensitive, lined by endoderm. Outside the anal canal, there is anal sphincters The anal sphincter one is the internal anal sphincter. The length of the internal anal sphincter is 3 to 4 centimeter. It is nothing but the thickening of the circular muscle coat of the rectum, which forms the internal anal sphincter of the anal canal. It is tonically active. This internal anal sphincter is in the state of contraction that provides a basal tone in the anal canal. It is supplied by the pelvic splanching nerves, which contains both the sympathetic and the parasympathetic fibers. Sympathetic fiber from L1 to L3, and the parasympathetic is S2 at 4. So these pelvic splanching nerve supplies the internal anal sphincter, and that is the involuntary control, and this internal sphincter is tonically active that provides the basal anal pressure. It is contracted all the time. The external sphincter is the puborectalis, which is continuous with the levator ani, and the puborectalis is attached posteriorly to the anorectal junction, and anteriorly it is attached to the pubic symphysis. The external sphincter muscle is a skeletal muscle. It consists of 3 parts: the profundus part, the most proximal, and then the superficial part of the external anal sphincter, and then the subcutaneous part of the external anal sphincter. This puborectalis is the external anal sphincter, which is a skeletal muscle supplied by the pudendal nerve, which is a branch of the inferior rectal nerve, and this sphincter provides the squeezing pressure of the anal canal. When you want to squeeze the anal canal, the external anal sphincter contract. This external anal sphincter provides the anorectal angle, which will provide the continence of the flatus and feces. It is only relaxed at the time of defecation. The angle is obliterated, and the rectum, the anal canal, is in straight line, which results in the relaxation of the internal anal sphincter first, and then the external anal sphincter, and by the action of the muscle of the lower abdominal wall contract, the act of defecation is started, and expels the fecal content to the outside. That is about the surgical anatomy of the anal canal. The commonest pathology you see related to the anal canal is the hemorrhoids. Hemorrhoids, these are the vascular cushions arising from the lower part of the rectum and the anal canal. These are not the veins. These are the arteriovenous connections which have got a pulsatile flow. The hemorrhoids, which are above the level of the dentate line, they are known as the internal hemorrhoids, and the hemorrhoids which appear below the level of dentate line, lined by the skin or inoderm, they are known as the external hemorrhoids. The internal hemorrhoids, they are at the position of the left lateral 3 o'clock, on the right side on the thoracic position 7 and 11 o'clock. That is the distribution of the opinion of the spear rectal artery, because it divides into 2 branches, right and left. Left remain undivided, and right divided into anterior and the posterior branch. which is seen on the anatomical position and the thoracic position at 7 and 11 o'clock positions. These are the vascular cushion. In fact, they are AV connection, arteriovenous connection, and having a pulsatile flow. That is why in hemorrhoids, the bleeding occurs, there may be very much blood loss, which can present patient with severe anemia. The underlying cause of the hemorrhoids is the excessive straining at the time of defecations. Patients are usually constipated, low residual diet, take less amount of water, and they are constipated, they sit in the toilet for a longer time. This straining is one of the factors which leads to hemorrhoids. Excessive straining at the time of defecation. The hemorrhoids, they present with two symptoms. One is the bleeding, per rectum, fresh blood at the end or the start of defecation. Knee pathology is in the anal canal. The second hemorrhoid, they can prolapse, which can present as a mass at the anal verge. Internal hemorrhoids, when they slide down the dentate line, overlying skin, overlying mucosa is excoriated because of staining or hard stools, and the patient complains of bleeding per rectum, fresh blood, either at the beginning of defecation or at the end of defecation. The fresh drops of blood fall on the surface of the stool, and that is first degree internal hemorrhoids. The internal hemorrhoids, they prolapse, they slide down just above the dentate line, and the presentation is bleeding per rectum. That is the presentation of first degree hemorrhoids. Second degree hemorrhoids, these internal hemorrhoids, they prolapse at the anal verge at the time of defecation, and after that act of defecation, these hemorrhoid mass which appear at the anal verge disappears. This is called second degree hemorrhoids. The third degree hemorrhoids, they prolapse at the time of defecation, and then after that you have to push these masses with your own hand in the back passage. They are reduced manually. This type of hemorrhoids called third degree hemorrhoids. The fourth degree hemorrhoids, the hemorrhoids, they are permanently collapsed at the anal verge. They do not reduce either spontaneously or manually. That is called fourth degree hemorrhoids. The treatment of the internal hemorrhoids depend upon the degree of the hemorrhoids. The patient has bleeding per rectum, fresh blood on the stool. You suspect hemorrhoids, which may be primary hemorrhoids, and you do the rectal examination followed by proctoscopy. You find their hemorrhoids, they are present in any of 3, 7, and 11 o'clock positions. What is the treatment of first degree hemorrhoids? Treatment of first degree hemorrhoids primarily is the dietary manipulation. You increase the roughage in the diet by salad, vegetables, sabol, and the stool softeners like Duflex. You increase that intake of water and do some sort of exercise, just like walking. By this dietary manipulation, you increase the bulk of the stools. When you increase the intake of fluids, the stool become wet, and this constipation is resolved and there is no straining at the time of defecation, and patient become better. Avoid chilies because it irritates the mucosa of the lower part of the rectum and the anal canal. If the bleeding doesn't stop, then you can do the sclerotherapy, 5% phenol in almond oil. Majority of the patient, they do respond to dental manipulation, but if the bleeding persists, you can inject in the submucosal, and this 5% phenol in almond oil, the 5% phenol is a carbolic acid. It is a sclerosing agent. It causes fibrosis and shrinkage of the AV connection in the submucosa of the lower part of the rectum and anal canal. The almond oil, it acts as a base. It does not allow the absorption of carbolic acid. The local stay is increased, and that has a subsequently good effect to stop the bleeding, provided the injection is placed properly and the volume of this 5% phenol in almond oil is 3 to 5 centimeters. The first injection at the pedicle of the hemorrhoids at the anorectal junction is a very effective method to control the bleeding and cause fibrosis. The volume should be good and the injection should be placed at the right place submucosally. 2 superficial injections cause sloughing of the mucosa, and the 2 deep injections which cross the fascia of the non-biliar into the prostate, which can severe degree of prostatitis and pain in the rectum. So, placement of the sclerotherapy is very important. It should be at the level of the pedicle of hemorrhoids, at the level of anorectal junction in the pedicle, not in the fundus. Second thing is that it should be neither be too superficial, not too deep. Superficial cause mucosal abscesses, and the deep injection cause severe degree of prostatitis or prostatic abscess. That is a complication of this sclerotherapy in first degree hemorrhoids. Second degree hemorrhoids, the mass appear at the anal verge at the time of defecation and disappears spontaneously. The treatment, again, very important, is dental manipulation, increase the fish and fluids, and the sitz bath and the stool softeners. Avoid the chilies, spices, and there are 2 options. If there is a 1 hemorrhoids or 2 second degree, you can do the band ligation. Band ligation you can do without anesthesia because the hemorrhoids, they are internal above the dentate line. This band ligation is very effective, provided you place the band properly. Don't place the band on the external hemorrhoids because it's lined by skin or endoderm. The pain sensitive is absolute contraindication of band ligation in the external hemorrhoids which are lined by the endoderm of the skin. Never do the band ligation at 3 sites. You can do 1 or at the maximum 2 band. If you apply 3 bands at one time, there may be necrosis and chances of development of the anal stricture is there. Band ligation is a painless process. If there is severe pain, your band is not at the right place. It is rather on the anoderm below the level of dentate line. Bleeding occurs after the band ligation is because sloughing of the mucosa. Very effective treatment for second degree hemorrhoids. And sometimes if the band ligation is not available, you can even do the sclerotherapy for second degree hemorrhoids. The third degree hemorrhoids or the 4th degree hemorrhoids, some people advise to have band ligation at 1 place or 2 places, but Regarding the 4-degree hemorrhage, the treatment of choice is St. Mark's ligation or no ligation, an axial of the hemorrhoids, which is called Milligan-Morgan method of ligations, that is called as the formal hemorrhoidectomy at 3 quadrant. If there are 3 hemorrhoids, one is at 3 o'clock, 7 or 11 o'clock. This hemorrhoidectomy is a very carefully performed operations. The majority of surgeons, they do not know how to deal this hemorrhoidectomy on the operation table. The most important thing you should keep in mind, the hemorrhoidal vessels, they are superficial to the internal anal sphincter. When you excise the hemorrhoids, the sphincter is visually visible, and your dissection to excise the mass is right down to the internal anal sphincter. Don't stitch the internal anal sphincter. Mass is superficial. When you ligate the pedicle, you take the stitch in the internal anal sphincter, which subsequently later on very severe pain after hemorrhoidectomy. That is the most important thing. Majority of the people, they do sphincterotomy or GTN cream is absolutely rubbish, because the pain in hemorrhoidectomy is physiological to some extent, but if the pain is very severe, it means you have either taken the stitch off through the internal anal sphincter. You should dissect the hemorrhoidal mass up to the internal anal sphincter. Don't go through the internal anal sphincter, which causes a very severe pain after the hemorrhoidectomy. It is very important, you must leave the islands of the enoderm between the hemorrhoidectomy sites, because the enoderm is a skin. If you take too much skin when you are doing hemorrhoidectomy, the patient will develop post-operatively very serious complication that is called anal stenosis. It is very important, you must leave the islands of the anal and mucosa and the enoderm in between the hemorrhoidectomy sites, from where the skin can grow or enoderm can grow. Otherwise, you will then get the anal stricture. That's a long-term complication of hemorrhoidectomy when you take too much enoderm during hemorrhoidectomy. That leads subsequent later on anal dilatation or subsequent endoplasty. It's a dreadful complication. Still, post-operatively, one thing is very important. If the patient has lower abdominal pain, you must palpate the bladder. Majority of the hemorrhoidectomy done under spinal anesthesia, and they take a lot of fluid during anesthesia, which causes diuresis, and the bladder is distended, and because of the pain, he can't pass the urine, and the pain becomes further perpetuated. So it is very important to palpate the bladder after the hemorrhoidectomy. Try to give less fluid during the operation. The second complication is the bleeding after hemorrhoidectomy. The patient can present as a hypovolemic shock, tachycardia, no obvious bleeding at the anal verge. Probably the bleeding is occurring in the rectum. The patient becomes in shock, not because of spinal anesthesia, because of the hypotension and tachycardia. Take the patient to the operation theater under general anesthesia, put the patient in the third position, evacuate the blood and tie the ligating vessels, because these slipping of ligature can cause diffuse hemorrhage, because there is a pulsatile flow is in the hemorrhoidal artery. So that is all about the hemorrhoidectomy. Dietary manipulation and sclerotherapy degree 1 first degree hemorrhoids, dietary manipulation, sclerotherapy or band ligation, second degree hemorrhoids, third degree and fourth degree hemorrhage, ideally you should perform the hemorrhoidectomy, that is low ligation and excision of the hemorrhoids, which is called St. Mark's ligation. It's a very good operation, very effective operation for the third and fourth degree hemorrhoids, provided you know how to do it. Most of the complication of hemorrhoidectomy is severe post-operative pain, because you take a stitch of the internal and sphincter along it, or post-operatively if too much inner derm is taken during hemorrhoidectomy, the patient will develop anal stricture, which is a dreadful complication. Majority of the hemorrhoids, the wound heals in 3 to 4 weeks times. You only advise to have a 6-bath, stool softener, high fiber diet, and a lot of fluids. The second pathology you see in the perianal area is the external hemorrhoids. The external hemorrhoids really present with the thrombosed external hemorrhoid. What happens, because the external hemorrhoids, they are lined by the skin or the enoderm. Staining can cause rupture of the vein at the anal verge on the lower part of the anal canal, present as a mass. The patient complained with severe pain for last 1 day or 2 days with the appearance of a mass at the anal verge. The diagnosis is thrombosed external hemorrhoid, because external hemorrhoids, they are lined by the skin. The skin is quite tight over it, and rupture of the veins can cause a swelling which is very tender, because overlying skin is very sensitive. If the patient comes to you within 48 hours with the pain in the back passage and the appearance of the mass at the anal verge, the diagnosis is external thrombosed hemorrhoid. The treatment is under local or general anesthesia. You have to excise by making a elliptical incision. The mass should be excised. Don't open it and evacuate the hematoma. It will again lead to formation of a perianal hematoma. Better thing is, within 48 hours of the pain and the appearance of the mass at the anal verge, you must excise it by making a elliptical incision and excise the hematoma. If the patient comes after 72 hours, then you leave it open and evacuate. This is going to be resolved as either the skin tag, or if it gets infected, there may be a perianal abscess. So treat accordingly, leave alone, just surgical intervention, then the patient develops perianal abscess. Otherwise, majority of the patient, this hematoma after 72 hours, it resolves, the pain subside. Usually. This is second pathology which appear as a mass with pain in the back passage. The other pathology which can cause the pain in the back passage is the anal fissure. This anal fissure is a crack or longitudinal split or tear in the lower half of the anal canal below the dentate line. Because lower half of the anal canal below the dentate line is pain sensitive, it is lined by the enoderm and it is supplied by the somatic nerves. Due to staining and the constipation as a result of the hard stools, there is a longitudinal split in the enoderm in the majority of the patient in midline posterior at 6 o'clock position, but in ladies sometimes because of the obstructive labor, you may have got a fissure in the midline interiorly at 12 o'clock position. Usually 90% midline posteriorly and 10% of the cases, especially in the females, because of the obstetric trauma, obstructive labor, that may be cause ischemia and tear of the in the midline interiorly at 12 o'clock. This is called anterior fissure. If the fissure occurs in the lateral wall of the anal canal, it is unlikely it is more likely to be pathological. Underlying disease may be inflammatory bowel disease, Crohn's disease, or ulcerative colitis. So you should not touch these fissures aggressively with the surgery. Or the fissure at the lateral wall may be because of traumatic or maybe HI, human immunodeficient virus, sexually transmitted disease, which can cause fissure at the lateral margin, but usually the chronic inflammatory disease like Crohn's disease and ulcerative colitis must keep in mind. So don't these fissures aggressively with surgery. No sphincterotomy and no surgical procedure should be done when you suspect the inflammatory bowel disease, the underlying etiology of this fissure. The treatment, if you look the clinical examination history and the clinical examination, the anus is tightly closed because of the spasm of the internal anal sphincter. You don't find any finding except the pinhole anus tightly contracted, and patient complained of pain at the time of defecation and after the act of defecation for a while. The diagnosis is very simple and straightforward. Majority of the time you can diagnose by taking the history and looking at the anal verge. The treatment, is no need of rectal examination and the proctoscope because it's contraindicated. Patient cannot tolerate the fingering and any instrument. Because when this slit or tear occurs in the floor of the tear, there is running of the fibers of the internal anal sphincter. When you do any manipulation, this internal anal sphincter goes into severe spasm and there is a severe pain. So no intervention at all in anal fissure if it is diagnosed perioperatively by history and clinical examination. The treatment in acute fissures for a few days, a week, is the GTN, glyceryl trinitrate, is a vasodilator absorbed from the perianal skin and cause the relaxation of the internal anal sphincter. Blood flow is increased and patient feel better, and the sphincter spasm go away, and you can perform the defecation. You can go to toilet 10 minutes before you can apply GTN, and you can also use the GTN cream 0.4% 3 times a day by massaging the skin well away from the anal verge, and that can cause the relaxation of the internal anal sphincter and improves the blood flow to the anal canal, which leads to healing of the fissure. Second is stool softeners, high residual diet, and of course a lot of fluids with sitz bath. Majority of the acute anal fissure, they heal up in 3 to 4 weeks times, and this is the treatment and medical management of the acute fissures. In our experience, the chronic fissure in which present with the sentinel pile and history is for months or even years, intermittent remission and relapse. These chronic fissures, they have a sentinel pile at the lower end and hypertrophic papilla at the proximal end. These fissures, they do not respond to GTN and the treatment or the lichenocaine gels or stool softeners, because the patient is psychologically is very much depressed because the pain, this fissure has got a symptom of relapse and remissions. I think the best treatment for the chronic fissure which has already been tried by the medical treatment, is the surgery. The surgical treatment of the chronic fissure is that you must do the rectal examination under anesthesia to look at, there should be no, the fissure sometimes present as a carcinoma of the anal canal. Sometimes you find the fissure is on the laterally placed, which may be underlying Crohn's disease or inflammatory bowel disease. One should be very careful after doing the rectal examinations to rule out the cancer of the anal canal or the inflammatory bowel disease like proctitis and the Crohn's disease, which can present fissure laterally or sometimes medially. The treatment is the lateral partial internal sphincterotomy, because this, when you divide the fiber of the sphincter, the spasm goes away, blood flow to the anal canal is increased, because it is a spasm of the internal anal sphincter which does not allow the blood to go into the anal canal or into the anal mucosa. The sphincterotomy should be done lateral sphincterotomy. It may be open or it may be closed. It makes no difference at all. The sphincterotomy, which is done through the floor of the fissure, that at 6 o'clock, when you divide the fibers of the internal anal sphincter in the floor of the fissure, this treatment is very effective, but the thing is that there is a guttering action, because that is a dependent part. But if you perform the lateral sphincterotomy either through the anal canal or you do the closed partial internal sphincterotomy, it makes no difference. Both are very effective. The only thing is there is no guttering action when you perform the open lateral sphincterotomy, because when you say lateral, it means it at 4 o'clock or at 8 o'clock. So these are not the dependent areas. When you do the dorsal sphincterotomy through the fissure, then that has got a guttering action. The fecal matter can stay on in the dependent part in the midline posteriorly, and there is swelling of the underclothes. Lateral sphincterotomy, no matter you do open or close, there is no guttering action. There is no chances of any infection, because the incision is open. Because when you place the incision in the lateral wall of the anal canal, the length of the incision is not more than 3 centimeter. That is below the level of dentate line. Don't go above the level of dentate line. 3 centimeter is good enough to divide the fibers of lower half of the internal anal sphincter. So this sphincterotomy, and other method is that you don't go to the anal canal, you palpate the internal anal sphincter and the external anal sphincter, and you take the knife of number 11, you hit at the 8 o'clock, at a 4 o'clock position, and go inside between the intersphincteric space, and then you turn the knife and the cutting edge towards the anal canal, and you divide the fibers of the internal anal sphincter. Avoid to open the anal mucosa, because if the anal mucosa is opened, then the chances of infection is there, because it's a closed space, bleeding is bound to occur. If the germs will go through this lining, or there is a nick in the anal mucosa, then the germs can enter in the blind space between the internal and the external anal sphincter. You can get a perianal abscess. By and large, if there is no violation of the anal mucosa in closed partial lateral sphincterotomy, the results are as good as the open partial lateral sphincterotomy. The sphincterotomy should be 2 centimeter, or at the most is 2.5 centimeter or 1 inch, just below the level dentate line. Very effective procedures. You can do either the open or the closed. The point is you divide the fibers of the internal anal sphincter in its lower half, and the position should be lateral. Either you do closed sphincterotomy or you do the open sphincterotomy through the anal canal. Very effective procedure. The only complication is fecal incontinence. It is only 0.1%, but one person should know how to divide the fibers of internal anal sphincter, not the external anal sphincter. Then the problem arises of anal incontinence. incidence is 0.1%. It is more common in the people who are above the age of 50 and 60, where the tone of the internal anal sphincter is low. One should divide the fibers less than half the length of the sphincter. But this fecal incontinence which appears, if you have done the right operation, it will disappear in a couple of weeks or 3 weeks. Permanent incontinence is you have done the wrong operation, wrong selection of the surgeon and wrong selection of the site. You don't know the depth of the cutting of the fibers. So that is the treatment of the chronic fissure in ano. That is lateral, partial, internal sphincterotomy, open or closed method. Closed method, you go to the perianal space between the internal and external sphincter and you divide the fibers of the internal anal sphincter. And this procedure, and of course if the sentinel pile is there, you must excise that sentinel pile. This fissure is bound to heal if you have done the proper operation, has improved the blood flow to the anal canal by dividing the fibers of the internal anal sphincter. The inferior rectal artery is not constricted one, flow is improved and the fissure is bound to heal. That is about the fissure in ano. The third one is the anal pathology or perianal pathology, is the anorectal abscess. It is the infection of the anal glands which lie in the intersphincteric space or in the anal crypts where the duct open at their bases. Is perianal abscess, is maybe perianal abscess or anorectal abscess is divided into 3 types of abscesses. One is the perianal abscess of the transsphincteric abscesses, ischiorectal abscess or supralevator abscess. The treatment of the perianal abscess is the incision and drainage through the perianal skin, and you drain the abscess. 40% of the cases they may end in perianal fistulas. The abscesses which are not visible on the perianal skin, it means the abscess is either the intersphincteric abscess or is the supralevator abscess which can be drained internally in the rectum. That is why sometimes a fever, pain on defecation, not responding, no evidence of any perianal impression. The answer is the abscess is either intersphincteric, which can be drained internally in the rectum by making incision, or it may be supralevator abscess which can be drained internally. Majority of the abscess which are drained, the wound healing is by secondary intention. Abscess should be properly drained, avoid the damage to the sphincters. Majority of the perianal abscess which have been drained properly, I again say drained properly, they leave the pocket of the abscess behind. Either they become very much rough, that damage the sphincter fiber without knowing that this abscess is intersphincteric, and the intersphincteric abscess and the ischiorectal abscess, they can be like a horseshoe shape. So 30% of the perianal abscess later on develop in the perianal fistulas because the residual infection is left over in the anal glands and there is a continuous or intermittent discharge through the perianal skin which present as the perianal fistula. That is also one of the important cause of pain in or around the back passage is the anorectal abscess, thrombosed external hemorrhoid which I have already discussed, fissure in ano, and the fourth one is the thrombosed internal-external prolapse hemorrhoids. If there is a prolapse hemorrhoid, 4-degree hemorrhoids, sometimes it's difficult to differentiate from the that is called as the rectal prolapse. But if you look at the anal verge, these prolapse hemorrhoids, they come down, they slide in the form of columns, and they appear as a radial masses. And when you look at the procedentia of the rectal prolapse on the anal examination, at the anal verge you find there is a pink circular grooves of that marks that this is a rectal prolapse. And if you have got a radial masses, then it is a prolapsed internal external hemorrhoids. So it is very important to differentiate a 4-degree prolapse hemorrhoid versus procedentia, or the what is called as the rectal prolapse. In rectal prolapse, you find the circular grooves on the pink mucosa of the rectum, while the prolapse hemorrhoids, they present as a radial masses, because the hemorrhoids, they descend down in the form of column and present as a radial masses at different position at C7 or 11 o'clock position, depending on the location of the masses. And the last pathology which I discuss in this one is the fistula. The perianal fistulas, or the fistula, is abnormal communication between the two epithelial surface. The fistula may be low or high. It is basically infection of the anal glands, and the abscess can travel through the sphincter or between the sphincter, appear as the opening on the perianal skin, and as a perianal fistula. It is a blind tract lined by the granulation tissue between the two epithelial surface. The fistula may be low or high. Majority of the fistula, 50% they are high and 50% they are low. Simple fistula, which may be intersphincteric or low transsphincteric, you can do the fistulotomy by the young surgeons, and you can code out the fistula by this experienced surgeon who has done a work in the proctology or the colorectal department. By and large, they do fistulotomy and they carrot it, and the healing takes place by secondary intention. In low fistula, you do the fistulotomy or fistulectomy. They are below the level of the anal sphincters, either intersphincteric or low transsphincteric, which is only involving the subcutaneous part of the external anal sphincter. The high fistula are the high transsphincteric or excess sphincteric fistulas. If the fistula tract is going through the major portion of the external anal sphincter is below that, this is called high transsphincteric fistula, and some of the fistula tract goes outside the sphincter and opening into the rectum is called extrasphincteric fistula. The high fistula, they are complex fistulas. They should not be dealt by the young surgeons, because it is very much important to diagnose on the operation table is the fistula is low and high. If the high fistula, the distal tract should be excised or poured out, but when it's going through the sphincter, you have to apply the citron ring around the sphincter, because if you will go through it, you will damage this external anal sphincter, and patient will be the candidate for permanent anal incontinence. So the high fistula, that is high transsphincteric or excess sphincteric fistulas, distal part of the fistula should be excised. The proximal part of the fistula is opening to the rectum. They should be past the citron ring and tie around it, and then you can subsequently, these sphincter fiber, they will cut and heal, and you call after every 3 weeks to change the citron ring and carotage the tract, and ultimately it depends on the length of the sphincter which is involved, and it may take first three weeks, maybe once, twice or thrice. It's difficult to say. It depends upon how much sphincter is involved or how much sphincter is below the level of the citron ring. So these are high fistulas. The only complication is incontinence. The other complication, majority of the fistula by the young surgeon, they treat as a low fistula, and that will cause a recurrence. The perianal fistula is a disease which can occur 70 times if you do not treat it properly. You don't trace the tract right up to the internal opening, which either lies in the anal canal or in the rectum. So I will still strongly believe the proctology and the fistula surgery is the most dangerous surgery, more difficult than the cholecystectomy and appendectomy, because just to excise the tract is not the operation. No MRI, no CT scan, no fistulogram help to identify is the fistula is low and high. I again repeat, no investigation will help to find out is a low fistula and high fistula, no matter MRI, no matter CT scan, no matter fistula or not, is all rubbish in the eyes of the experienced surgeons. The fistula track, either it's low and high, will be decided on the operation table by the surgeons, and he will say how the track is going up through the lower part of the sphincter, through the upper part of sphincter, or outside the sphincter, entering into the rectum. These complicated fistula surgery should not be dealt by the surgeons. Every surgeon who has done FCP is doing the fistulectomy, same way as he doing cholecystectomy. For God's sake, this is a very serious surgery because anal canal cells are like the cells of the brain, and one should be very careful because any complication in this area is hell, and you don't know, the patient will go through the great misery. I have seen my own eyes the cases of the fistulectomy and hemorrhagectomy, which is horrible post-operatory, and और पंजाबी कहने वो बददुआओं ही देते रहते हैं सर्जन को. For God's sake, be careful. Do not perform this fistula surgery by a young surgeons. If you don't have experience, you can do two things. Either you will damage the sphincters, one, or you will do every fistula as a low track, and you excise the fistula, and you will find after a couple of months, the opening will appear somewhere around the anal verge again. So be careful. It's very important to differentiate low fistula, high fistula. Low is intertranssphincteric between the internal and anal sphincter. The opening is very close to the anal verge, and the low transsphincteric fistula, you have to trace the track. And if it's going to the lower part of the fibers of the external anal sphincter, you can sacrifice them because the bulk of the sphincter is above the fistulous tract, that is profundus part and the subcutaneous part. But if the track is going to the greater portion of the external anal sphincter, that is involving the not only the subcutaneous part but also the superficial part of the external anal sphincter, or which is going through the profundus part of the external anal sphincter, then don't do it. You just put a ceton ring and leave alone. So that is my humble submission for the fistula surgery. One is the recurrence, and the second is the anal incontinence. Anal incontinence is less common because most of the surgeons, they treat them as a low fistula because they don't want to have a complication which is lethal, and they will never leave the surgeon till either he become dead or the surgeon become dead, because that anal incontinence, and later on you have to repair the anal sphincter with covering, pelvic colostomy, and what are the results of repair of the anal sphincter is still controversial. That is all about the fistulas. And other pathology which occur in the anal canal is the carcinoma of the anal canal. If the cancer is above the level of the dentate line, it presents as a bleeding and a mass, and you pass the proctoscope and you take a biopsy. If it turns out to be squamous cell carcinoma, the treatment is chemoradiation. I again repeat, carcinoma of the anal canal above the dentate line, histology shows squamous cell carcinoma, or the treatment is chemoradiation, that is radiotherapy plus 5-fluorouracil with what is called as the methotrexate. Or so if 80% of people, they do respond with chemoradiations, 20% there is a failure of medical treatment recurrence, or the tumor has invaded the anal sphincter, then you can do the abdominal resections. The second histopathology is the adenocarcinoma. The treatment in usually adenocarcinoma that has infiltrated the anal sphincter, the treatment is abdominal resections. The third pathology of the carcinoma of the anal canal above the dental